Thank you for the introduction, thank you for the invitation, and for the topic also. This is my disclosure of interest. I didn't put any disclosure of interest about politics, but I think many did. I have no. As a preamble, I would say that I would like to remind you something very simple, in fact, and perhaps it explains a lot of things. Finally, when you want a shot at individual level, it's the perception of the relationship between efficacy, effectiveness, and adverse drug reaction and adverse reaction against vaccine. And this can switch very, very fast, in fact. It's a perception. So it depends on already what Jacques said a lot about newspaper, about many things. So we have to keep in mind this, and perhaps it explains a lot of things, but perhaps it explains much more things, and it has been already said. It's at collective level. Vaccine policies is dependent of public health policies. Many experts, you are here, but politics, how politics take the expertise and how they want to take it. So we have to deal with this and keep this in mind all along my presentation. Thank you. And perhaps it's very simple. See, if you have for flu vaccine in US, where in the state, because there is different state, if I remain well, in United States also, and here you see when flu is mandatory, there is no problem. In France, it's really funny, you know. This is all recommended for healthcare workers. This is mandatory. No problem. So I finished my presentation. But perhaps for healthcare worker, it's more important to make sense and to make sense for healthcare. So perhaps we will see all this thing around why we have to vaccine, why we have to vaccinate healthcare workers, are vaccine efficient or not, and perhaps how to do better, and we'll see if there are some explanation. Of course, the problem is herd immunity. Of course, when you are in contact, more in contact with microorganisms like healthcare worker, you can get disease. So you want with vaccine protect healthcare workers, but also because healthcare workers, because of cross transmission, you can imagine that if you vaccine healthcare worker, you prevent disease in patients. So this is the famous herd immunity. But the message is here: different risk, different transmission, different disease, measles, hepatitis B, I will take the example, and different level of risk. And we will see with flu is the mess and incredible things, because it changes everywhere at any location. I will say again later. So if we take hepatitis B, it's a high prevalent disease in between 0.1 to 20% in Europe. Seroprevalence is higher in healthcare workers, and finally in the United States you say that you have 0.5% of healthcare workers with seropositivity. However, actually, the transmission from patient to healthcare worker is very, very low. And when you look at the transmission risk from healthcare worker to a patient, it's exceptional. And if you remember well, in France, 95% of people accept to be vaccinated. It's mandatory. And the risk is very low. Remind you what I said at the beginning about the perception. The perception of hepatitis B is very, very bad. The perception of flu is a very small disease, a very benign disease. As you can see here, in 2000, 2014 and 2015 in France, it was only 18,000 excess deaths. But it's in old people. So you have new place in nursing home. In nursing home, to say, outbreaks, it was 410 outbreaks declared. You can multiply by 2 or 3, in fact. At this time, it was 40,000 residents, and inside there is a direct death, 5%. And this year, it was a fantastic year. This year now, we know it's a very new data. It's more than 20,000 excess deaths in 2 months. We were quite early, 800 outbreaks. I don't know if it's flu or not, but each year, at the time we have flu, we are in the flu season, we have an excess death. And this year we know that there is also with respiratory virus, syncytial virus also, metapneumovirus also in the same times. And perhaps flu is only responsible for 15,000 deaths, excess deaths. That's not a lot. So in Europe, you can say that it's 4,000 to 220,000 excess deaths each year. But is it a real burden? As I said yesterday, do we measure disability induced by flu? I'm sure that each person here will experiment flu, if you are not vaccinated, of course. Reminds that it was quite an heavy disease, and after it takes time. Imagine when you are 80, 90, that's now. And I have a question about the normal rate of death outside the flu season, because you know the flu season begins, it's an epidemiological point of view, it begins when you have more than 150 cases per 100,000 inhabitants, and it's finished. And just before, you are not in the flu season, and just after, you are not in the flu season. So if you dead outside the flu season, you are not dead. It's not an excess death due to flu. It's incredible, but it's like that. So is there nosocomial influenza, in fact? Flu in healthcare worker, higher risks than lay public, it's known. Attack rates, it's in between 13 and 23%. There are a lot of asymptomatic forms now we know, and it's proven. So when you look at the nosocomial infection for flu, it's in between 10 and 50% outbreaks inside the outbreaks. The death rate vary from 5 to 60%. How can you imagine root data, or people say, want to believe experts, and when you said as an expert, it's between 5 and 60%. Say, what is this expert? But we don't explain that flu is different. The outbreak is different in my hospital than in the hospital of Annecy, which is 100 kilometers only. It's not at the same time, at the same level. We know that, but we don't explain. And we have not experts, or perhaps not, or needs more humility. They trust in their data, and after they sell and sell and sell their data, thinking that they are the lonely, rude and true data. But flu change everywhere in the place and also at the time. So why do we vaccine for healthcare worker? Just to have a large look. High risk for healthcare acquisition, it's hepatitis B, but it's not a lot. When you put everything inside, it's influenza. Sometimes, of course, measles, pertussis also, but much more in children, but it happens also in France in elderly population. When to say that there are different risks, we have to say that each time different risk, different level of risk, Of course, when you are here, different goals. And when you are here, different level of risk, influenza, each year it could be really different. So first take-home messages, VPDs still affect a high level of the healthcare system. VPDs affect healthcare system and patient safety at very different level, and we have some different expertise on that, and we can communicate on that. And many transmission of VPDs to patients are related to healthcare workers. And for this, influenza is for sure the main. So are vaccine efficient? You already heard that it's not, we have not a lot of good vaccine against flu, but for an healthcare worker, what you can say, I'm not sure it's good to say that to an healthcare worker. You will lose 2 days outside the hospital if you vaccine. So perhaps it's not good. But you gain that. You decrease LI for 43%, and everything together, we said it's around 60% efficacy, but it's not so bad at all. Is there any drug reaction? As I said before, the perception of people at individual level, it's in between the safety and the efficacy. The efficacy is here, effectiveness, and the safety. And the safety is quite good. We can say that the perception of a safety, it's very different a place to another. So are we some evident data about the efficiency of vaccine, flu vaccine for healthcare workers to protect patients? We have only 3 RCTs, and it's in nursing home. It's this, perhaps it's the, I'm very proud of this data. It's not mine, but very proud for older people, because we have no, I would say after, but I will emphasize on it, no data for adults. This is the free RCT, which has been done, carried out in nursing home. And what you see, it was clustered RCT. It's not perfect, it's clustered, and compared as well 10 to 10, 23 to 23, and 20 to 20, with vaccine coverage different place to another. And as you can look here in France, incredibly at this time, because it's old, the coverage rate without any intervention was quite high as compared to here to Hayward studies. But each time you find here with unadjusted result, a decrease in mortality. Here, less effect, but it was quite interesting to see that the mortality in resident decreased nearly 20%. And when you have the R squared, it explains 20% of the variability of the mortality during the flu season. So it was quite impressive, and you can see in between control arm and vaccine arm. And much more interesting, it was significant whatever vaccine status of resident and whatever the functional status of the resident. And this it means really something for a geriatrician and for old people also. So it means we have some data. And here, to systematic review. Usually I put another title on this. I made a recent barrier to vaccinate. Expertise. The expertise of the Cochrane twice, it's to say that it doesn't work. With the same data, I'm not an expert in epidemiology, but the same data, and they find something different. So perhaps somebody here will explain to me. But what I'm sure, it's on 2013, Thomas, it's Cochrane review, the influence of Cochrane review, decided that the outcome decided in the free study was not good, so he changed it. This is expert, international expert. We have to think about that. It's so important. Efficacy, in other words, and in other words, I would say inside adult and day-to-day care hospital, no nursing home. It's a short-term acute care. There is no single RCT. But how can you make an RCT? You take everybody during the flu season and you need to follow them outside the hospital. And actually, in France, they decided to cut a lot the length of stay in hospital, so we will have a lot of people to follow. So it means it's possible, but it's billions to make such study. But so no RCT. So if we are, I would say, very hard for evidence, when we say we need RCT, actually, we cannot say anything about the protection of healthcare worker from flu for patient. But we have some arguments. In high-risk ward, at least. Nosocomial influenza, it's between 20 and 60% in this high-risk ward. We have nosocomial influenza, even though, or despite we take all the other measures, infection control, hand washing, isolation, pills, antiviral drugs, and we have still a nosocomial influenza, meaning that perhaps it lacks something. And we have some links in between vaccine programs and a reduction of nosocomial infection. I will show you after a long-term program. So when you look at European level now, the coverage, so we have some vaccine which work. Not very good, but it works. Good is better than better, perhaps. And look at the vaccination coverage. In influenza, worldwide, it's between 0 and 90%. In hepatitis B, everywhere it's mandatory, you are at 90%. Everywhere it's not mandatory, it's very low. I didn't take all the studies. Now it's hundreds of studies about uptake of flu vaccine in healthcare workers, but there is a very high variation. Norway, it's very funny. It's 0% when you make the mean. It's in between 0.2, 0.3, because there are some in the same country. Some are the uptake is nearly 50%, and over is 0%. So I mean, Jacques already said we need vaccine coverage feedback to improve, but at this time 0% you can improve it for sure. So Japan is very good. Germany, I'm sorry, I lose it. It was 25%. France was 35%. But here, I didn't really make a good job. But here is it 2010. Here it's 2016. And as already shown, it changed a lot. And perhaps it changed from a countryside to a countryside because of special action, governmental action, public health institution action. So be careful with the data. And here, to come back to hepatitis B, what are the policies? For influenza, all are recommended. For out of 30 countries, 29 were recommended flu vaccination for healthcare workers. And you know how it's important, how it kills. See hepatitis B. Mandatory in 9. Mandatory in 9 countries. And you see how it's important. We have to think about that. But the discrepancy, even inside the expertise. So how to do better? I don't know, somebody said something about barriers, acceptance, hesitancy. It's nearly the same. You can read it. You will have the slides after, so it's not important, and we are quite late. So there are some about individual reason for declining, of course, about vaccine, but also about influenza. And as I said, it's benign disease, it's not contagious, there is not real nosocomial transmission, etc., as usual. And there are some organizational reasons. One, a link we find, I don't know if your country, but there is a very high difference in between occupational medicine, who have to take care of the healthcare workers to be vaccinated in France, and infection control, who count the number of nosocomial infection, nosocomial flu infection, but they didn't discuss together in France. It means you cannot trace or implement a new program when you are like this. It was futile. Here to say that in between words, and it was in Geneva, I think, or in Switzerland, you think that in gastroenterology, in rheumatology, in different words, you have very, very, very different picture. In between patient, in between physician, resident, you have really, really different. It means that we don't share the same problem or in the same way. It means that we have different culture, and we have to change that. So this is a real interesting paper about vaccine hesitancy, and where we are, all these have to be taken into account if we want to do something about hesitancy. Meaning, imagine the work we have to do. If we want to change something, only here, together, and after, think about politics and make sure that the politics trust in you when you say something. I want to share with you a study we performed several years ago. It was 3 seasons. The first season, identification of the factors limiting, in geriatric words, the implementation of vaccine or vaccine coverage. The second was a program based on what we found. We said, in the same words, we come back and say, okay, we know what is your problem, we will explain to you. And we are teacher, so we know. And you will see for the program too. So what we do, something which is not reported a lot inside it was the bad image, particularly bad image of flu vaccine. It's particular, it was in France. And there was a bad image also of the older population. People work inside geriatric. But we have some question we can say, we can conclude of that. So when we built our educational program, it was myth, flu, and flu vaccine, myth and reality. And because we educate, and it was on flu, and in old population, made a picture of a very beautiful old lady and a syringe inside. Here we find also, and you have to be careful of that also, that inside, it's only our group. There were after 3 years of the same question, there was 30% of people who were completely, staunchly opposed to the flu vaccine. Meaning that when you want to educate this person, if only one is in the room, it becomes difficult to pursue all other people. So we make this educational program, and as you see, it was 28%, 21% in control group, and unfortunately, because there was an alert about H1N1 this year in France, we increase the both. And remember, at this time, we said, it's funny, how can we do? And we asked for people who are much more involved in communication and like publicity. And we asked them to see what was good or not. And they said, your slide kit is perfect. You explain very well, but you communicate very badly. Because you say it's the bad image, it's flu vaccine, and you put on old slide a syringe, and you say the bad image was old, and you put on each slide an, of course, very beautiful but old lady. So it means each time people cannot think. So they say you have to think and change your slide kit. And at this time we said, young lady, young doctors, George Clooney, family, you know, and incentive and valorization at the end of the positive way of attitude of vaccination. When you get 50% coverage rate, you have some gift. So education is not good enough. We need better communication. And at this time, you see, it came back because there was no alert anymore. It came really back to in the control group. And despite a foreign effect, there was an return effect, and we enhanced. So it means it was not perfect, but what we were quite proud, it was stable rate in previous vaccinated healthcare workers, and we doubled the new vaccinated healthcare worker. It was not perfect, of course, but it means that you can begin by something. So at short term, I would say intervention to promote healthcare worker vaccination is all of this. You need all of this. Or all of this works, but it works very shortly. And you need to have long-term efficacy. Until 3 years ago, we have only 2 studies, reported studies, in United States, Salgado, who worked for 10 years. 10 years of implementation of different things to enhance and to arrive at 90% of vaccine coverage rate in healthcare worker for flu vaccination. So it means you can do it. And now we have several others and nearly in all continents. So it means that even with different culture, if you put inside enough works, enough people, it means enough money, you can reach probably. The example here by Elizabeth Frenzel in a cancer institute, and you see it's 8 years. And it's incentive, it's leaflets, it's what you want, it's everything and some constraint. Mask use, and here you see the uptake and the decrease in nosocomial infection. Flu nosocomial infection decrease as well, you enhance. We have to be careful of the data because you need to see in different seasons. As I said, flu seasons are different in place, different in time, so we have to have a follow-up of that to be sure it works. But it's years, 8 years, mobile time. Many persons involved. Mandatory vaccination is very fast. In the United States, it was here, you are here after, it was here. Now, you want to work here, you need to be vaccinated against flu. It's simple. And it works. And it costs really less. Other kind of restraints, declination forms. So you want to work here. Are you vaccinated? If you are not vaccinated, perhaps you are not in this ward because there are high-risk patients, or requirement of mask use for unvaccinated people, and you will see. So we can use different vaccination. So when you are here, you say, we have ethical consideration to take into account. In favor, when you want to mandate vaccination, you need to have a high prevalent disease with great impact. I cannot say anything about flu, even if some epidemiological, I would say religious epidemiological person think it's not. There is a real great impact of flu in old population. Need to have a benefit to healthcare worker and get herd immunity with healthcare vaccine. This is controversial. In nursing home, it's quite sure, but even the Cochrane say the opposite, so be careful. And we need to have voluntary program failed. And here it's controversial. As I said, numerous failed, but if you don't put all your force inside for a long time, you cannot change a culture. Change a culture, it's not days, it's not months, it's perhaps several years, at least 10. Against its healthcare autonomy. So my question is healthcare autonomy counterbalance the harm of the disease and the failure of voluntary programs, or the lack of willingness of public health institutions? So, my take-home message are, at scientific level, we have to be clear, we need to determine the burden of a disease. All the disease, it's so important. We have to keep humble, to be have a kind of humility and trust in our data, but better explain. High variability of flu season, and of course, high variability impact on patient. And of course, healthcare worker vaccination will have a different impact in a place to another and a time to other time. So we have to explain that to the government, of course, and institution. At organization level and institutional level, there is an urgent need to clear European guidance for that. And Jacques Gaia said a lot of things better than me about that. We need to determine who provide the vaccine, who control, and which are the targets. Which are the targets? We said already. You said it, but it's 10 years ago, and we are still there. At healthcare worker level, of course, still large lack of knowledge. Whatever, GPs. But I can ask for infectious disease specialists also, as I said this morning, all the risk group for pneumococcal vaccination. I'm not sure, or I'm quite sure, that in the room here, even specialists cannot give me all. So it means it's complex to have the better knowledge, the best knowledge, sorry. We can implement multidimensional programs adapted to each VPDs and vaccine. It is possible, it works, it takes time, it changes culture, so it costs a lot. Mandatory vaccination is cheaper, of course, it's the cheaper solution, but need to activate, I think, an ethical debate, probably at local where you work, but also at national and European level. And finally, I would say that, yes, there is vaccination, but there is not only vaccination. There is a bundle of acts, hand washing, face masks, early detection of the disease with the PCR now. It's very easy. In several hours, we know if there is or not. And you know that you can isolate patient. After a while, put all the floor in quarantine, avoiding new admission if you are at this time, prompt use of antiviral, eviction of healthcare worker, all of things are good. We did it. We did it this year. It was funny. In geriatric ward, hand washing, and we control it. 80% face mask, twice a week. Somebody look at them, at us, and see if healthcare workers wear correctly the mask. It was 82% in the middle. For visitors, it was 70%. Visitors, so it was not visitors who gave the flu. Early detection, it was systematic. Quarantine, it was done. avoiding new admission, impossible in acute care. As Jacques Gaillat said, we were in the flu season, it was completely crazy. But each person, old person inside put a foot in the the acute care, use antiviral, 100%. Prompt use of antiviral, everybody 100%. Eviction of healthcare worker, done. Nosocomial infection, 20%. Vaccine healthcare worker, only 53%. Thank you for your attention. Okay.
You're talking about mandatory vaccinations for healthcare workers, but also how about for patient populations where this is a standard of care, nursing homes?
Yeah, in nursing homes, at least in France, but in Europe it is quite different, but the level is quite high. In France, it's not a standard orders, but only with asking to people or family, because half are demented, we are at 93% of vaccine coverage for flu. So it's not a problem. The vaccine of patient inside nursing home is not a problem. At the opposite, as Jacques Gaillat already showed you, in aging population in community, it's a problem. We are more near 50% only, and as you know, it's only half work or 30%, meaning that it doesn't work a lot. Yeah.
So I heard earlier that the rate of pneumonia, cause of death, is in 3rd place in Europe, and it's in 9th place in the U.S. Do you think that's a vaccine difference?
I will answer in two ways. First, the question is, what are the data from? As I said before, the diagnosis of pneumonia is completely crazy. I read paper, and some paper I don't believe a single word, because the diagnosis is completely wrong. It's not the same, or perhaps they give antibiotics to people who have symptoms, respiratory symptoms, and people are getting better and they said it's pneumonia. But really, pneumonia, it's really different. This is a part of the answer. After, I think it could change from a time to a time. And if we look, for example, this year, we will have a very high burden of death from flu and complication, much more complication of flu, for example. But if you took 2 years ago, nothing, no signal, no excess of death, no a single excess of death. And at this time, we have the same level of vaccination, but no death, meaning that at this time probably we were at the 9th place and not at the 3rd. Thank you.